Hello, my name is Aimei Bor, and I am a University College London medical student passionate about equity in healthcare. I am privileged to be given this opportunity to present my project on deafness and pregnancy, a service evaluation including the perspectives of healthcare professionals, deaf service users, and interpreters. I'd like to acknowledge my supervisors Jana Richens and Melissa Witten. This service evaluation aimed to explore the current provision of maternity care for pregnant women who are deaf. For context, capital D deaf refers to people who identify themselves as culturally deaf and part of the deaf community. Lowercase d deaf is a medical condition of acquiring significant hearing loss. Throughout this evaluation, we use capital D/lower d deaf to identify patients whose hearing has a significant impact on their needs. The social model of disability transfers the perception of disability from one's difference to the structural barriers within society. Deaf people have a right not to be discriminated against. Article 14 of the Human Rights Act prohibits discrimination on the basis of disability. In the UK, the 2010 Equality Act requires service providers to make reasonable adjustments for disabled people. In the UK, hearing loss affects 12 million people. The World Health Organization estimates 6.1% of the world's population has disabling hearing loss. There are over 200 forms of sign language used around the world today. British Sign Language is used in the UK. When communicating with deaf people, you should never make assumptions. Individuals have diverse levels and preferences for using sign language, hearing aids, reading, lip reading, and verbalization. An estimated 9.4% of women giving birth in the UK have one or more limiting long-standing illnesses which may cause disability affecting pregnancy, birth, and beyond. No data relates specifically to deafness and pregnancy. Impairment is individual to that person alone and touches every aspect of that individual's life, manifesting itself in physical, emotional, psychological, environmental, educational, social, spiritual, and financial dimensions. Deafness and pregnancy are two concepts rarely considered together. Our narrative review used the SPIDER framework to find disparities in care and research recommendations relevant to deafness and pregnancy. The Medline search found 25 sources which we organised into four main themes. Obstetric outcomes. A 2016 study of 17.9 million deliveries in America by Mitra found women with hearing loss were significantly more likely to have preterm birth and low birth weight compared with hearing counterparts. Communication. A study in the USA in 2006 found 91% of hearing women reported getting a lot of information about prenatal care from their doctor, compared to 61% of deaf women. Reasonable adjustments. A study in the USA found deaf-friendly baby monitors were not well known among hospital staff. Interpretation. Provision of qualified interpreters correlates with a higher overall satisfaction of maternity care for deaf women. The wait time for interpreters invoked significant anxiety for some deaf women. Overall, there is an international lack of research dedicated to deafness and pregnancy. The case studies and interviews found suggest that deaf women lack autonomy in their maternity care compared to hearing counterparts. This evaluation is based at University College London Hospital, UCH. Over 6,000 babies are born each year in the Elizabeth Garrett Anderson maternity wing. The number of deaf women entering maternity services at UCH is unrecorded. In-person interpreters at UCH are provided by Language Line Solutions. In 2014, the article in the centre shows a deaf couple who had no interpreter provided during their forceps delivery at UCH. They felt confused, anxious, and said this amounted to discrimination. The British Deaf Association said that their case reflects the experience of many deaf people in the NHS. Despite disability equality legislation dating from 1995, it was only in 2018 that the first disability and pregnancy guideline was created at UCH. This project aimed to evaluate the current provision of maternity care for pregnant women who are deaf. It comprises of two parts. 1. A UCLH questionnaire for health professionals to evaluate the knowledge and confidence of UCLH staff in relation to deafness and pregnancy. 2. Discussions with interpreters, case-loading midwives, and deaf service users to explore holistically the nature of maternity care provided to deaf women. In parallel, paper questionnaires were distributed at UCLH and discussions with the three stakeholders, interpreters, case-loading midwives, and deaf service users were conducted. The questionnaire consisted of a mix of Likert scale and open text questions so the knowledge and confidence of UCLH staff on deafness and pregnancy could be established. Quantitative data was analysed on SPSS. The AAA framework on the right-hand side of the slide has been adopted into this evaluation as the method of thematic analysis for qualitative data in the questionnaire and discussions with stakeholders. It is an adaptation of the AAAQ tool, which is a human rights-based approach to redressing inequitable health outcomes. Now I will go through the results, starting with the questionnaire. In total, there were 113 questionnaire respondents, which were thought to be representative of the UCLH maternity ward in terms of role and area of practice. 58.4% of the cohort had cared for one or more women with profound hearing loss in the prior 5 years. 36.3% of participants indicated yes, they were aware of the UCLH Disability and Pregnancy Guideline. A greater proportion of midwives were aware compared to doctors. Low awareness may be explained by suboptimal circulation of the guideline or be reflective of the few encounters staff at UCLH had with women with disabilities. Chi-squared analysis found no evidence of an association between awareness of the UCLH Disability and Pregnancy Guideline and the confidence in caring for deaf pregnant women. 60.6% of the questionnaire cohort indicated a guideline specific to deafness and pregnancy would be very useful. When asked about adaptations and adjustments for the maternity care of deaf women, for both equipment and support, over 50% of the cohort left this question blank or indicated not sure. Visual aids and sign languages were relatively well-known adjustments. However, digital technologies, adaptations in the birth plan, and maternity-specific adaptations, such as deaf-friendly baby monitors, were mentioned by a small minority. The graph on the left shows overall confidence in providing maternity care for a deaf woman. The graph on the right shows confidence in arranging an interpreter in the maternity care for deaf women. Confidence ratings were from 1 to 5, where 1 equals not confident and 5 equals very confident. Mean overall confidence in providing care was 2.67 out of a maximum of 5. Mean confidence among midwives was 2.77, and for doctors was 2.65. For arranging an interpreter for a deaf pregnant woman, the mean across the cohort was 2.56 out of a maximum of 5. Confirmed by a Mann-Whitney U test, there was a significant difference between midwives who had a mean confidence of 2.85 and doctors who had a mean of 2.19. None of the doctors who responded to the questionnaire rated their confidence as 5 for arranging interpreting services for deaf pregnant women. Spearman's correlation analysis found that only 8.6% of the variation in overall confidence is explained by its relationship with confidence in arranging interpretation. The other component of this project consisted of discussions with interpreters, caseloading midwives, and deaf service users to explore deafness and pregnancy. Transcripts from these discussions were analysed and organised into themes under 3 main headings. 1. Accessibility of information. 2. Availability of interpreters. 3. Acceptability of the support for people with deafness or impaired hearing. Using this framework, I will now integrate responses from the UCLH questionnaires open text answers and the qualitative discussions with these 3 stakeholders to explore the main concerns and suggestions for improvements related to deafness and pregnancy. On the left-hand side are questionnaire responses, and on the right-hand side are excerpts from discussions with the 3 stakeholders. The 3 main concerns of health professionals in our questionnaire were communication, difficulty booking interpreters, and emergency situations. This was reflected in our qualitative discussions, where all 3 stakeholders expressed concern over booking interpreters. The deaf service user found they don't always book interpreters, which caused her hours of waiting or cancelled appointments after she had arrived at hospital. The caseloading midwife found the interpreter booking system confusing, and despite female interpreters typically being booked for labours, one interpreter recalled a scenario where a male interpreter was booked for a birth last minute. They had no interpreter for throughout the whole thing, and they were just desperate for anybody. Important to the deaf service user was her difficulty in contacting the hospital. She found it unfair. If it's just a hearing person, they can just call and get an answer. Getting informed consent was another key concern for health professionals in our questionnaire. The caseloading midwives we spoke to also found that consent for urgent antibiotics of a deaf woman they were caring for kind of had to be retrospective. It was almost a best interest sort of approach, despite the deaf woman having capacity. Again, I have the questionnaire responses on the left-hand side and excerpts from discussions with stakeholders on the right-hand side. 60.6% of the questionnaire participants indicated a more specific guideline for deafness and pregnancy would be very useful, and more staff training was the most common suggestion for improvement from questionnaire participants. All participants in the service evaluation agreed better access to interpreters would be useful. For the birth situation, an interpreter suggested a pool setup which consists of a team of on-call maternity interpreters ready for the birth is the ideal strategy to ensure the availability of interpreters. Both interpreters and the deaf couple we spoke to found the 6-hour antenatal class that they attended was too information-dense and exhausting. As one questionnaire participant put it, they seemed to be fitted into the normal pathway, which is not appropriate. Continuity of care was a recurring theme in our evaluation. The case-loading midwives emphasised that their care of a deaf woman would be impossible without continuity. To summarise findings of the service evaluation, deaf women receive inequitable maternity care due to low awareness of hospital disability guidelines and limited knowledge of maternity-specific adjustments for deaf women. Staff confidence in arranging interpreters and caring for deaf pregnant women could be improved. And poor communication impacts the autonomy of deaf women in their pregnancies, for example, by detracting from informed consent. Facilitators of care, which may improve a deaf woman's experience of childbirth, include continuity of care, improved training and guidelines for staff, and better use of technologies in healthcare, such as greater awareness among staff of deaf-friendly baby monitors and easier ways for deaf users to contact hospitals. Limitations of our service evaluation include COVID-19, which impacted data collection and the format of discussions with stakeholders, questionnaire phrasing, which may explain the low response rate of health professionals in our questionnaire when asked of additional equipment and support for deaf women in pregnancy, representability, as qualitative discussions were only with 3 stakeholders, and due to time and limitations in word count, only the most frequent themes from discussions with stakeholders were analysed in depth. And now a quick slide linking COVID, deafness and healthcare. The Where is the Interpreter campaign was launched in October 2020 in response to the UK government who gave no confirmation of providing a live platform British Sign Language interpreter during their daily COVID briefings. Masks in public and hospitals are negatively impacting deaf people's experiences of healthcare. COVID-19 prompted the charity Sign Health to launch BSL Health Access, a 24/7 video relay interpretation service free of charge for deaf people in health settings. At UCLH, COVID-19 led to the installation of 6 machines around the hospital for remote access to interpreters. If sustained, better access to video relay interpreters could improve access to interpreters and enhance the maternity care received by deaf women. More work must be done to improve the equity of maternity care for deaf women. Here are our future research recommendations. On local terms, piloting an updated UCLH disability and pregnancy guideline and re-evaluating the provision of maternity care for deaf women. More service evaluations on deafness and pregnancy in multiple settings. Focus on quantifying the number of deaf users in maternity services and their birth outcomes. Evaluation of how effectively technologies are implemented in maternity settings to improve care provided to deaf women. And more research focused in the views of interpreters and partners of deaf service users. Thank you for listening to this talk. Here are some takeaway messages. Deaf women receive inequitable maternity care. Continuity and communication is key. And we hope this evaluation will help you reflect on how maternity services and individual staff can empower deaf couples in their pregnancies. In the words of one questionnaire respondent, deaf women need support all the way from antenatal care to post-delivery. Let's make them feel part of society. I'd like to acknowledge my supervisors for their encouragement throughout this project, as well as all service users, interpreters and health professionals who have supported the project. It was a privilege to hear about your experiences. I welcome any questions and feedback at the live Q&A session, or I am happy to be contacted via this email to discuss further anything covered in this presentation. Thank you for listening.